Thank you very much. I'm really happy and delighted to be here. And it's a really pleasure to share with you my genius experience and the way I'm treating my patient in class 2 treatment. I want to thank Charlie for the invitation. It's a great pleasure to be here, and it's my third Genius Summit. And also, I'm really pleased to take part of this great adventure with the Genius Master, with our great family. It's very exciting for me to share every day and to learn more from cases of different participants. I want to thank him for being in this first Master Edition. Today, my topic is about class 2 treatment and the way to treat them efficiently. And let me say it's a combination between two major components. First of all, we're going to speak about the tool. And it's really necessary in your daily practice to have a reliable tool which will help you in your daily practice. But at the same moment, it's very important also to get what we call the thinking process or protocols for treatment. And this is the way to simplify your daily practice. I think this is my conviction. Simplicity is not ease, and I think ease is a great trait. But simplicity, it means when we have a good diagnosis, when we have a good protocols, then we can establish treatment goals. Then we have to get the reliable tool to get these results. That's my aim today. So for me, class 2 treatment is like struggling against the deleterious effect of our conventional mechanics. And many often, our conventional tools, they lead to deleterious effect and side effects which complicate our procedure. And this is what's speaking about also Dr. Kalab, about the controller lower incisor, about the occlusal plane. And we will see today how we can, with the Genius system, avoid all these effects. So, but first of all, what are the key learning objectives of this conferences? We're gonna emphasize about the diagnosis, because for me, it's very important to get the main criteria diagnosis of the class 2. When we get it, you can easily plan your treatment, then decide what kind of goals you can achieve. Second thing, it is the conventional approaches. We will see what is good, what is bad of the conventional approaches. And finally, I will suggest you my approach, which is a combination of the Genius system. But let me say for you, the main idea that I want to share with you today, I'm thinking vertical. I changed my way of thinking, of treating class 2. Certainly for you, it's a horizontal problem. But for me, I have to emphasize about the vertical dimension. And this is the key. Class 2 treatment is about 40 to 60% of our daily practice towards the profit. If we want to see what kind of class 2 we have, many often it is about mandibular retrusion. At about a half of patient treated, we have for 25% a maxillary protrusion and a mixed clinical form. It means at 75% of our patient treated are retrogradic mandible. This is the main problem on this class 2. I did some stats in my office. This is my previous clinic. Now I'm working with my partner, which is here. I wanna tell her, happy to see you here. And what I noticed that in class 2, I'm treating for 156 cases for the first 8 months. They are class 2. About 55% of my patients are class 2. And I'm looking at a vertical dimension, about a half is a brachyfacial, 35% is a mesodivergent patient, and 30% is about dolichofacial patient. What is the definition of class 2? Toward the American Board of Orthodontics, class 2 is a relationship between molars. It's only a definition about the sagittal way. I think it's very restrictive definition. We have the half class 2, the full class 2, but let me say in the nature you never find more than full class 2. It doesn't exist. But as I told you previously, it's a very restrictive of a definition, because for me, class 2 is a semiology. It's not about relationship between molars, upper and lower molars. It's first of all a skeleton pattern. It means for me, class 2 is a skeletal class 2. And this is very important to keep in mind. This makes you have a new view of, a new approach of your treatment. And it's also functional and aesthetic treatment. And it is about upper airway, narrowing, But more importantly, with class 2, unfortunately, we have a lot of TMG compression. And this is the main problem when we get when those patients that come in the office. We can find a locked mandible with a compression joint, and this leads or enhances a degenerative process. So we have to find solution to this semiology. Let's talk about facial growth, and this is very interesting to keep in mind. We are all born in class 2. This is at the beginning, and the skull is a class 2. And what happened when the teeth is coming, there's a kind of verticalization of the face, and the mandible adapt in a forward position. What is happening here in the red line is the occlusal plane. At the birth in the skull, the occlusal plane is across the condyle. And when teeth are coming, and the eruption of upper molar, the occlusal plane is gradually flattening, and this is pushing the mandible in forward rotation. And what we get is an increase of what we call the DPU, the distance between condyle and occlusal plane. This is very important because this will help you to put into your treatment, your strategy treatment. This is an interesting study done by Professor Sado in the University of Japan, and it is a superimposition of 200 patients from 6 to 15 years old. And what he notes that in this superimposition, we have an increase in posterior height of upper molar, and this increase of posterior height will push the mandible forward, and we have a gradual flattening of the occlusal plane. This is the way that this growth is working in order to let mandible adapt in a forward position. He did another study, and for class 2 dolicho patient or hyperdivergent patient, and he noted that there is a lack of eruption of upper molar, so we have a decreased posterior height, and what happened, the mandible is locked in a forward rotation. They cannot adapt in class 1. So what happened with really that he concluded that the mandible failed to adapt in class 1 because we all born in class 2, and this is a process of adaptation, and with the gradual flattening of occlusal plane that let the mandible go forward. Maybe this is the main idea I want to share with you. We have to get strategy of treatment to let this mandible go forward. So what are the common problems? Let's summarize. It's a retinatic mandible, functional disturbances, such as swallowing, breathing. We're going to speak also about guidance. This is very important in order to guide the mandible in a forward position and to stabilize our treatment. The steep occlusal plane, this is what happened in a hyperdivergent patient. And finally, discoordinated arch form. It means many often what we get in a class 2, we have a problem of upper arch enlargement and V-shaped upper arch, and this will lock the mandible in a retrognatic position. And keep it please in mind, we're gonna speak about the vertical dimension. This is the key of our approach today. Good news, there's a mandibular advancement. There's a lot of study done, such as randomized clinical trial or even systematic review, and now it's demonstrated that we have growth. And this is an interesting study done by Herbst, and this is a regenerative process in the condyle and even in the temporal fossa, and this is what let mandible go forward. This is good news. We have a lot of tools that we are using on a daily practice, activator, Bauer scope, Mara, advancing, even in aligners, they get the bite jumping to let the mandible go forward. But unfortunately, all these tools have a deleterious effect. And the most common deleterious effect, that flaring of lower incisor, and they also getting an intruding of upper molar, making the occlusal plane more steeper, and this will not help us to let the mandible go forward. So this is a common problem of this conventional way. Same things of heavy class 2 elastic. I'm using them at the end of treatment, and those elastic are anchored in the lower molar, and they are also steepening the occlusal plane, and they give such side effects, such as rabbiting effect, flare and flower incisor, and I think it's not the right way to treat patient, especially hyperdivergent patient. It means if we use heavy elastic at the end of treatment, what we're gonna get, we gotta open more and more the bite, and the mandible will go backward, and this is what we not have, what we don't need to get in this kind of treatment. So let's summarize. With all these tools, they have a palatal version of upper incisor, lower incisor buccal version. We have a backward rotation of the mandible. This is the lack of control of the occlusal plane, then the mandible came backward. Then, many often we get a steep posterior occlusal plane. We saw that in a hyperdivergent patient. And more importantly for me, the TMG compression, and this is if we cannot let the mandible totally free, we will enhance the degenerative process in the condyle, and this is not a healthy treatment. So what is the solution? Honestly, I'm doing a little bit of research about the way we can treat efficiently our patient, class 2 patient, and avoiding the deleterious effect. And this was published in Angular Orthodontics, and this is in a protocol with anchored elastic, heavy elastic, in the mini plates. As a conclusion, the author said there is a dental-alveolar effect and are eliminated, all the deleterious effects are eliminated, but honestly, it's not my way of treating. I'm not, really I want to have a forward. I want to avoid deleterious effect, but honestly, I can't find myself in my office when a parent came with his child and tell him, well, we're gonna treat it, no braces, we're just gonna use mini plates. I don't think it's the right way. It's very invasive as an approach. So for me, the solution is, in another term, how can we achieve clinically excellent results in the most effective, consistent, efficient, and patient-friendly manner. This is very important for me. We have to be simple, and we use also braces in a simple way and not in a complicated way. So my approach are aimed in two components. First of all, the vertical approach. That's what I told you. I'm not thinking horizontal. Second thing, I'm really concerned about mandibular adaptation, how to let this mandible go forward in order to fix my class 2. This is my guidelines. And this guidelines was also taken from the meow technique, and it's very interesting as a guidelines. First of all, we have to get what we call the sagittal and transversal upper arch enlargement. If we want the mandible get forward, we have to eliminate all obstacles. We have to unlock the mandible. And this is the first condition. And many often, the problem is the maxillary. In V-shaped forms, this maxillary will avoid the mandibular advancement. Even when we get class 2 division to this palatal version of upper incisor, will lock the mandible in a retrognatic position. So first, unlock the mandible. Second thing, we have to unload the temporomandibular joint. And that's why we use a bite ramps. That's why we use a bite turbo. And here the main idea is to create a regenerative process and avoid this compression in the condyle, which can help us to push the mandible forward. Then we have to control our occlusal plane, and especially the posterior occlusal plane. And as we saw it in the saddle study, many often what we get is this very steep occlusal plane. What we want to get is to flatten it and increase the posterior height. That's why the mandible will go forward. The two last condition is about stability. If we want to lock the mandible, once we correct it in a protrusive way, position, we have to establish or to provide what we call the retrusive guidance. This is contact, the initial contact between first, upper, and lower premolar. This is essential to let the mandible stable. And finally, we have to get an arch coordination. And at the moment, we can stabilize the mandible and stabilize our correction in class 1. So I tried to summarize and to make this for you, this animation. So what I did first, in taking the example of class 2 division 2, first we have to unlock the mandible and develop the upper arch in a sagittal and transversal way. This is the role of the genius system I'm using in developing the light forces, which help me to enlarge my upper arch. So this is what we do first. This is in a sagittal way. And at the second moment, we use bitrams to unlock the mandible and unload the temporomandibular joint, avoiding this compression. Second thing, now the mandible, we are creating condition to enhance the regenerative process and to push the mandible forward. Now it's the role of elastics. We are going to use shorties. They're elastic, very light, at the beginning of treatment from 4 to 6, then we switch from 3 to 5. And here what are we doing? We are building a new occlusal plane, and we are giving a vertical support to our treatment. It means when we enhance advancement in the mandible, if we want to stabilize that mandible in a forward position, we have to extrude the upper molar and give a vertical support. What we're using as elastic here, basketball, 2 ounces, no more. We are working in a vertical way, not in a sagittal way. This is very important. Finally, what we're doing is trying to get what we call the retrusive guidance by extruding premolars and to get this initial contact to let the mandible stable in a forward position. Let's begin with simple cases. This came in my office. This was concerned about her smile. This is not great class 2. Here, as you see, half class 2 on the left side, small class 2 on the right side. There's a little bit of lower incisor flaring. And what about herself? We have class 2 skeletal, steep occlusal plane, and a protruded lower incisor. And what we did is simply the protocol, it means we are enlarging, preparing the mandible for advancement, and posterior bitram and elastics. That's all. And then the mandible will go forward, and we are acting in a vertical way, and we are sure that we can fix this class 2. This is the final result. This is her smile. And let me be honest with you, what I appreciate a lot for this system is the torque control. I'm not thinking about because I have system which is working for me. That's why I'm just here focusing on my protocols, and I know that the system is reliable in terms of control. This is very important. And what I do usually to avoid lower incisor flaring, we have precise control in a torque in the mean 6 degree in the lower incisor, but many often I'm doing stripping and the torquing chain in order to control my axis floor incisor. Another more complicated case is a class 2. He's 10 years old, and here we have a V-shaped arch form, huge crowding here, no place for this canine, even in this lower canine. And the treatment here, let me see the pen. Yes, no place for this canine and the lower canine. And what about the ceph? The mandible is located in a retrognatic position. We have class 2 skeletal, but we have also protruded lower incisor. So I'm just beginning working my system and letting the 014 thermal ultra working for a long period of time, and here the aim is to develop the upper arch and create space for the canine using coil springs. And let's progress. Once we get the place of the lateral incisor, we'll flip the bracket. I'm just anticipating the 014 thermal ultra, and here we try to enhance a good torque control. Here's some finishing to do in the axis, but this is the final result. We got class 1 skeletal. We're still in protruded lower incisor, but here the final results. Occlusion. But let's see the support and position. As Dr. Collab said, what we want to get is this forward rotation of the mandible. I don't need backward rotation, and the mandible will grow in a vertical way, but it will go forward. This is very important. Certainly, we have a little bit of flaring of incisor, but all the study is, let me be clear about that, we cannot have 100% correction by skeletal effect. There's also some side effects, but it's well controlled, and this is what makes this system strong. It helps us to have a good control of the lower incisor. And once again, what happened is extruding the upper molar and the lower molar, and many often in this class 2 deep bite or class 2 hypodivergent patient, we have a lack of growth of upper and lower molars. So we have to increase them to extrude them and to enhance some vertical growth and forward rotation of the mandible. Final result of the smile. The profile, I think, is a quite interesting profile, and what I appreciate a lot is the projection of upper incisor. We have a good control, and this is very interesting. So what is the protocol now for dolichofacial patient, hyperdivergent patient? First, the torque selection. If you are working with a PSL Genius system, when we use an O14 thermal ultra, we have to anticipate the leveling effect of the wire. So we have to select the torque first of all. Second thing, upper arch enlargement. In order to unlock the mandible, let the wire work for a long period of time. Then we begin by controlling the lower incisor accents. It means at many often when we get in a class 2 skeletal, there's a compensation and the lower incisor flared. And if we want to enhance forward rotation, we have to control what we call the intercoronal open space. We have to create an overjet and we control the lower incisor, then the mandible can go forward. So what we're doing here is eliminating the posterior interferences by using bite ramps in 6 or 7, and class 3 elastic in order to control the lower incisor axis. I know it's a little bit confusing because in a class 2 we begin with class 3, but the main idea is to avoid flaring and control the posterior occlusal plane. And once we upright all the molars and we control our incisor, we switch in a class 2 elastic and posterior anterior bite ramp in order to enhance this forward rotation of the mandible. Finally, providing guidance retrusive guidance, and upper and lower arch coordination. So this is patient came in my office, he's 13 years old, and when we saw his pan, no place for the canine, and what happened, look at this molar, we are tilted mesially. And this is a kind of compensation, no place for the canine, all the molars go forward. And when I look to her ceph, we have to make difference between two occlusal plane. There is anterior and posterior occlusal plane. We don't have to think only there's one plane. And when we begin thinking that, we see things different way. Here what we get is a very steep occlusal plane in the posterior segment. And what we got about the ceph is the retruded mandible, skeletal class 2, steep occlusal plane, and here's a hyperdivergent facial pattern. But when we look in his occlusion, it seems to be class 1. This is the main difference. It means if we're still thinking about only occlusion, we cannot make the right diagnosis. The aim here is to think about the compensation. When we have class 2 skeletal, this is a kind of compensation, especially when there's no place for the canine. So here, decision for premolar extraction. But what I'm doing, I'm using a bite posterior tubal in order to unlock the mandible and let her go forward, and here getting space for the canine and controlling the lower of the axis for lower incisor, then using class 2 elastics. This is the final result, and what is interesting is about profile and his smile, and this is the main difference. Here in the chin, I think, is better chin projection, and this is the main idea of thinking by vertical more in a sagittal way. This is the ceph at the end of treatment. Analyze the ceph. We're still a little bit in class 2, but we have protruded lower incisor too. But we get a normal divergent facial pattern, and it means we reduce the hyperdivergency and let the mandible go forward. This is a very interesting. Another case in the same way, it seems to be class 1, but her chief complete, is about diastema. And here, what we note, if we look at the ceph, we have also retrognatic mandible, retruded mandible, and the flared lower incisor. And this is simple, but I think is a very complicated as treatment because we have to apply the upper incisor and create enough overjet to get this, to fix this or to close the diastema, but at the moment we have to enhance forward rotation of the mandible. So here what we're doing is trying to upright the molars to create space and avoid lower incisor flaring. And here's the protocol. I'm changing the elastic for suckers. Same thing, posterior by tramp. We are just treating the posterior occlusal plane and trying to upright all these segments and control the lower incisor axis. And then what we did anterior by turbo, then we switch elastic for class 2 elastics, light and short elastics with 014 thermal ultra. We continue working. And this is the final result. We have a nice occlusal, and we can close the diastema, and we have inter-angle incisor is very interesting. And this is, I think, should be one of the conditions to be stable. So the pan, same on the ceph. We are a normal divergent facial patient. We have good control with anterior rotation of the mandible, comparison of the ceph. And here, the mandibular occlusal plane, we are from 34 to 32. It's very interesting. And superopposition, once again, what is the effect here? We have good control of the mandibular rotation, and we extrude the upper molar, and this is the way to flatten the occlusal plane and enhance forward rotation of the mandible. Smile and her profile at the end of treatment. And once again, this is the profile. I think this is a better chin projection here. And what I appreciate a lot is the control of upper incisor. This is a very, very interesting. We have a precise torque which helps us to have this kind of result. Let's see class 2 brachyfacial now. What is the protocol? Here, the difference that we have an anterior interference. In the hyperdivergent patient, we are in a posterior interference. In a hypodivergent, with a palatal version of upper incisor, the mandible is locked. So what we have, first of all, the same protocol. We are anticipating the 014 thermal ultra effect. And what we are doing, upper arch enlargement to prepare for the mandibular advancement. Then we are bonding the lower arch and premolar by tramp short, class 2 elastic 4 to 6 and 3 to 5. In a mesodivergent patient, I'm usually beginning from 3 to 5. And finally, always providing the retrusive guidance and upper and lower arch coordination. How it works, this class 2 division 2, 13-year-old, retrusive mandible, here the chin in the retrusive position. And when we look on the upper arch, the mandibular is really locked in a posterior position. And this is palatal version is a degree problem. Here we have torque problem, for instance, and a severe curve of SPI. So here is the ceph, here is the pan, and the analysis, cephalometric analysis, class 2 skeletal, normal occlusal plane, hypodivergent facial pattern, and normal lower incisor inclination. So, just to remind you, the guidelines of the protocol, this I'm using. And let's see how it works step by step. First of all, upper arch enlargement, we are unlocking the mandible. And here we are using the 014 thermal ultra, and here only the wire is working for me. No anything else. And 1 month later, this is what I'm doing as a movement, just creating overjet intercolonal open space to enhance condition for mandibular advancement. So, second appointment, and this is very important, I'm bonding the lower and here, fortunately, I haven't the photos, but what I'm doing, anterior bite ramp here in premolar, and also short class 2 elastics from 4 to 6. And here it's very important to have a cooperative patient, because if the patient is not here for 3 or 4 months, maybe we can get some problem of mesial molar tipping. Honestly, I'm really lucky with this patient because he's a very cooperative. So 1 month later, elastic from 4 to 6. Then we switch. We use posterior bite ramp and elastic from 3 to 5. And here we continue working with retrusive guidance establishment to have this contact between first premolars in order to stabilize the mandible in a forward position. Final result, the end of treatment, smile, and once again, what is interesting, this profile, we can have better chin projection, and this is very interesting. Once again, good control of upper incisor, and this is what is important for me. What we did here is we take off the wisdom teeth, and this is very important because when we get a severe curve of SPI like this, what if you don't take off the wisdom teeth, you have a proclined lower incisor, and if you don't control your lower incisor axis, maybe you cannot let the mandible go forward, where you create another obstacle. Donc it's very important to take off the wisdom teeth. Here I just want to share with you the final occlusion, and this is a very important to detect. This is done by digital impression, and only the software tells me where are the maximum of contact. And here we get contact in the premolar, also maximum and lingual cuspid of premolar. This is the retrusive guidance, and no contact here in the upper incisor. And here we are in a stabilizing, no anterior interference at the end of mandible closing, and this is a very interesting to get as a result in terms of stability. So here no surgery, no premolar extraction, no TADs, just we have good tool with well-designed protocols and a very cooperative patient, and this we can have such interesting results. Finally, what I want to share with you today is to forget about thinking in a horizontal way. When you're treating class 2, many often what we're doing, we are focusing on a molar relationship. Class 2 is a skeletal class 2. And the main idea here is not to be obsessed by the use of heavy elastics, because they have a deleterious effect. The main idea, you have to think how to enhance forward rotation of the mandible. So first of all, we have to develop the upper arch in a sagittal and transversal way to unlock the mandible and to let her go forward. Unload the temporomandibular joint. This is very important. When you get a compression there, you can have a degenerative process. If you unload it, you are doing a medical and healthy treatment. Then, after that, you have to control your occlusal plane. Many often, in a hypodivergent cases, we have anterior interference, and it is posterior in hyperdivergent cases. So eliminate them and have the best control. And remember, life is adaptation. We have this ability to let the mandible adapt in a forward, and this is the target and the aim to correct your class 2. I'm really happy to share with you this exciting adventure that we get this year. It's really very important for me to speak about these guys, these people, these participants of the Genius Master, this first edition. I'm very glad to receive them in the office. We did courses, we did clinical session, we did case presentation. It's very rich as a master. And we have also good moments. We enjoyed a good moment, and this is a very important. I like sharing and I like knowing, and this is the sole way to progress together. This is the photo. Where's Bilal? The swimming pool is behind this photo. I'm inviting you. I hope to see you. And we have also a great dancer here with us. We can teach you the way to dance. It's a very great moment. Thank you very much, and I hope you will join us in the next Master Genius.